Hello, everyone. Welcome back to Oncology Brothers. I am Rahul Gosain, and along with my older brother, Rohit, he is older, we're going to dive into yet another important topic today, the management of colon cancer. If you're someone who's striving to keep up to date in this disease site, this one's for you. Today, we're honored to have Dr. Aparna Parikh, a medical oncologist, also my birthday twin, who focuses on colon cancer from Mass General Hospital. Dr. Parikh is also part of the NCCN Guideline Committee for Colorectal Cancer. With Dr. Parikh, we hope to cover her treatment algorithm for colon cancer. Aparna, thank you so much for joining us.
Of course. Thanks so much for having me.
Aparna, we have quite a bit to cover here. So we'll
Thank you.
start off with our localized disease, which is stage 1 and stage 2 first. In stage 1, these patients are diagnosed with incidental finding or on screening colonoscopy. They definitely need surveillance, but medical oncologists have very limited role here, or rather no role. And in stage 2, which gets tricky, especially after this revolution of circulating tumor DNA. Can you start us here on your treatment paradigm, particularly for stage 2?
Yeah, so I think stage two is sort of definitely an interesting area. And suffice it to say, I think a word of caution as we sort of dive into this area. I think some of the areas that we're going to be talking about, circulating tumor DNA, is still a rapidly evolving landscape. Much prospective clinical trial data is still needed. That being said, I think I'll make the argument today that I think there are some settings in the stage two scenario where I do think it's appropriate to use the test, and how I use the test. Again, having conversations with patients that this is still very much in its infancy, at least as a predictive biomarker, not necessarily prognostic. So, this stage two patient, let's start just talking through the MSS patients. We can come back to MSI later. But the MSS patients that are stage two low risk patients, we still, again, for risk stratification, we look at sort of the tried and tested clinical pathological features that have been around for quite some time. T4, lymph node status, how many lymph nodes are harvested, 12 or less, considered to be inadequate, perforation, obstruction, all of those things. And so if a patient doesn't have any of those features, we know that those patients do very well. And in that setting, feel very confident just offering surveillance. That being said, I think this is a scenario where I do start to have conversations around circulating tumor DNA, because there are a small number of patients that have low-risk stage 2 disease that do go on to recur. The caveat being is that in a low-risk patient population, when your baseline prevalence is low, you do have to worry about some false positives, right? And the way I discuss this with patients is that even the tools that we use, such as the clinical pathological features, we know that there's false positives there too, right? We're treating some that don't need treatment, and we are not treating others that would. And at least to date, circulating tumor DNA, the PPVs, as well as kind of the hazard ratios, have, routinely emerged as kind of a stronger predictive or prognostic biomarker. So having that conversation with patients saying, yeah, you could get a false positive, but we generally know that ctDNA detection is bad. And we've all seen the Kaplan-Meier curves of the positive patients, where kind of nearly all the patients who are ultimately positive will go on to recur. And we're starting to see now evidence that you can actually reverse that recurrence with chemotherapy. So a low-risk ctDNA, a ctDNA positive patient, I would actually offer chemotherapy to. And that chemotherapy, I would actually offer doublet chemotherapy too, just given the prognostic value of that. That being said, and we'll talk a little bit about this even with stage 3, I think in the positive patients that are low risk stage 3, similarly, when we think about 3 months versus 6 months of Kpox versus FOLFOX, I don't think we have a lot of time today to go into the idea, design, and some of the flaws with a non-inferiority design. But I'm probably the minority, but I'm generally a person who, errs on I don't personally love CAPE. I find that, you probably actually in the community setting do better than we do sometimes with CAPE. So I tend to be someone who will err on the side of, in stage 3 higher risk or even low risk patients who are younger, for example, who don't want to potentially compromise any cure, will err on the side of 6 months, but having a very low threshold to drop the oxali. So kind of staying very vigilant on top of the neuropathy. And at the earliest signs of someone getting neuropathy, you have to be a cycle or two ahead of it, right? Before you leave them, kind of really, really hurting down the line.
Aparna, thank you. There's so much to unpack just
I
with
know there's
stage 3. Just to dial the clock back a little, going back to ctDNA, you've mentioned that if it's positive, yes, we're all moving forward with chemotherapy. Be it negative or positive, are you following these patients serially, or are you using this test for one time to decide your adjuvant treatment?
I am not recommending it serially for everyone. Will I offer it? Yes. And will I have discussions? Yes. We, do have a clinical trial. So in that setting, of course. But I think that, the challenge, as as well as I do, is, we're scanning these patients depending on stage, twice a year-ish, to, especially the 3 patients, 2, maybe a little bit less. But so when you're scanning anyway, do we know, we don't have any treatment yet that we can give if a patient is positive. We know that negative doesn't necessarily mean there's no cancer there. There's still some limitations with sensitivity. We also know that if you were to be someone that recurs in a place that is potentially curative, like the lungs, ctDNA does a lousy job of detecting lung metastases, and a lung nodule that you're following over time that ends up being convincing for an oligometastatic site of recurrence. If you were just relying on the ctDNA testing, you wouldn't miss that too. So I do think it's something to talk about with patients, and I certainly want people to feel empowered in that shared decision making. And definitely have a lot of patients ask, and we'll certainly do it. But you have other patients that kind of get this, like, I don't know if I want to know, and then it feels like a little bit of a ticking time bomb. And then what are you going to do? You just scan a little bit earlier, and does scanning a little bit earlier actually do anything for outcomes? And I don't think we know that.
I have to jump on the same bandwagon. That's been my practice. And the other thing is, we mentioned T4. This is also where ctDNA data is, again, we're not diving into that all that deep, but it's not the best.
Yeah, and T4 disease I'm going to treat anyway, right? So a T4 patient, if you kind of look even previously from the dynamic study, T4 patients don't do as well. They almost do as badly as, a positive patient. So you're going to give them chemotherapy anyway. So in a T4 negative patient, I'm still not yet de-escalating care.
Now, diving into our stage 3 space, what is your management entails, especially now talking briefly about IDEA trial here? I know that whether would we utilize, if it is low risk, any thoughts on utilizing capecitabine approach for 3 months versus sticking with FOLFOX itself?
My practice is very heavily skewed towards younger patients. I run the young onset program here. And, with IDEA, in a non-inferiority study design, you have to accept, to call something non-inferior, you have to accept some loss of efficacy, right? And that loss of efficacy may be small, but in a younger patient, that few percentage loss of efficacy, it's sort of like oxali in stage 2, right? In a younger patient, you might have a little bit of a different discussion around how much you're going to push the oxali than in an older patient. And so, though 3 months of Capox is totally appropriate and would be guideline concordant, I, have had discussions with some of, some of these, and there's something about these like T1 tumors that are node positive, right? There's some data too that if you're a T1 tumor and you became node positive, like, oh, that's not great either. So there's these certain conversations that I have with patients around like, what does that actually mean? If you have any issues with CAPE, we could do this. And again, like, yes, it's a port, but, you can titrate it easily. You can stop the oxali early. So I'm a little bit of a, again, I acknowledge that I might be a little, I think I know of a few other people who kind of practice this way, and it may be a little bit my bias, but I tend to be, again, a little bit more on the full Fox and then drop early side of things, rather than CAPE and then kind of kicking myself later if people are having a hard time.
Well, I think at the end of the day, it's still patient-centered approach, and especially when you're talking about young patients, the chance of cure is what we are targeting here, and even slight toxicity increase with longer term here, and still giving them better chances of cure is certainly something advisable. So, thanks for going over your thought process here. Talking about the metastatic space. If you don't mind going over your first-line treatment regimen here, what are you exactly using, and is your decision based on sidedness or molecular information here?
Both. Yeah, both. So I think let's let's come back to immunotherapy maybe, and just stick on the MSS patients. So I think this algorithm is generally right. Again, biased towards younger patients. I think there is still, independent of BRAF V600E patients, there is still some small kind of survivable benefit with kind of triplet therapy, plus or minus Bev. And so even sometimes for the left-sided RAS wild-type patient, rather than just reverting straight to doublet plus or minus anti-EGFR, I will often use triplet therapy first. Obviously in someone who has a higher burden of disease, you want side reduction. And again, one of those things you peel back and you can go to maintenance, holidays over time. But in terms of someone, if you're like, okay, I don't necessarily think their burden of disease, even if they're young, warrants, like triplet seems like a little bit of an overkill. If they're RAS wild type and left-sided, I still think you have to have a discussion around anti-EGFR in the first line, especially, again, biased towards younger patients. I think you need anti-EGFR, of course, but, even from the paradigm study, many of the patients didn't get anti-EGFR in later lines of therapy. And so does withholding it in first line when you get it later actually, is that a detriment? I'm not sure we have that data. And so I'm not necessarily dogmatic around first line. You have to have anti-EGFR if you're left-sided. I think you absolutely have to have it in your treatment paradigm, but not necessarily in the first line. Maybe get and kind of preserve that quality of life a bit more, especially for the younger patients. But I think for the RAS mutant patient, definitely doublet Bev, right-sided patient, obviously same, that's doublet Bev that's right-sided and RAS wild type as well.
Aparna, thank you so much for going over that. Going back to the RAS wild type younger patient, when we're talking about anti-EGFR, let's say a small subset, but if this patient is HER2 amplified, are you still considering anti-EGFR at all in their paradigm, or knowing that they don't respond well, you're going to let that go and just rely on your anti-HER2 therapy eventually?
Let that go and rely on anti-HER2 directed therapy. Yeah. Yeah, I think pretty strong data that's a mechanism of resistance. Again, if you get to fourth, fifth, maybe you try it and just see what happens then, but certainly do not give it in earlier lines of therapy. Yeah, so RAS, yeah, exactly. So a first line RAS wild type patient who's known HER2, I would not give anti-EGFR.
Thank you for touching on that. I know we've briefly skipped over MSI high patients here and in early stage. Your treatment paradigm, we saw some data from Ipi-Nivo as well from GI ASCO, and this disease site looks exciting. We have pembrolizumab approved here. What are you doing in these settings? A patient that has MSI high, this is the same patient population where you can also see BRAF mutations as well.
Yeah, so I think the MSI still trumps BRAF, right? So even though there's that overlap, I think we still go to to immunotherapy first. I think we all are looking forward to seeing the Nivo alone arm from the GI-ASCO presentation. I think, certainly it's hard to ignore those kind of 2-year differences with those Kaplan-Meier curves from that study. I think one interesting thing to just point out from that study that is also important was there's from the Keynote study and then the Checkmate study. In Checkmate, also there's differences in the central testing that was happening in terms of MSI high status, and kind of we know that even at our kind of academic institutions, sometimes like it can be confusing in terms of whether the tumor is truly MSI high or not, and so I think we have to take that into account with the differences. So generally speaking, my prior to seeing that data, was just first line pembro, and then there are those rare patients that are just bulky MSI high disease, and then I would take pause of actually using ctDNA for monitoring those patients because I didn't want to lose the opportunity to again, FOLFOX you can give even if a Billy is 15, so you can get cytoreduction quite quickly with just doublet and don't need to worry about your LFTs there. But I think that 30% pembrolizumab non-responder rate in the bulky patients, I still started with immunotherapy, but there were patients where I gave immunochemo too, because I was like, I don't want to lose this window there, or just start IO and then monitor with cell-free DNA and kind of make sure you're getting a response there or switch to chemo. But now I think in those bulky patients, I haven't had one since GI-ASCO that I felt compelled to do Ipi-Nivo for, but sort of thinking about when that might come, I do feel like that I might actually try that Ipi-Nivo rather than Ipi chemo or just switching to chemo for the bulkier patients.
Absolutely.
It'll be intriguing and depending on how the trial plays out to see the nivolumab single arm.
Exactly. I think just all waiting for that arm to see where that plays.
Now, Aparna, in this particular patient, you started the patient on 5-FU base regimen, depending on the molecular signature here, if MSI high started on immunotherapy. Now the patient progressed. Now, 10 to 12 months out on progression of this disease, what are you considering for second and third line option, especially after fruquintinib being available as well with TAS-102, regorafenib?
Yeah, so assuming they're like a year out and it wasn't, they were on doublet alone and not a setting, for example, where you came back on maintenance and you're kind of going back, then obviously switching your chemotherapy backbone. So you've done that. You've done your anti-EGFR if you're RAS wild type. And I think highlighting the fact that they're RAS wild type in second line, even if they're right-sided, I will still give anti-EGFR therapy. I think that's important. And I think we're starting to realize with some biomarker analyses of even paradigm that it's probably not just, we knew it's not just sidedness, but we're starting to understand maybe what some of those, there may be some, resistant subclones that were there. So I do use anti-EGFR therapy in even in second line for a right-sided patient. So we've done all of that. I've been using Lonsurf and Bev even from the phase 2 data a few years ago. I think maybe now 2017, 2018, when the Lonsurf Bev data came out. And so that's generally my kind of refractory treatment of choice. I'm not a big Rego fan, even with the redose regimen starting at 80. I just didn't like it. I never saw any, true benefit. Certainly never saw any responses. I found even at 80, just people felt lousy on it. And I think, fruquintinib did get third line labeled. Definitely, I have given fruquintinib now, and a few people that don't want to, why do we need to do the infusion? Just do the pill. I'm not going to give Lonsurf to people we get people that come down from Maine, for example, and, you can kind of do quicker tox checks with them and send them on their way. So that's how I've only used it in a handful of patients. I do find it easier than Rego. So it is still a kind of TKI-ish type of side effects, but I have found it easier than Rego.
So TES 102 is something I have used biweekly. I've only used fruquintinib once, and I started off 5 milligrams, had to quickly decrease the dose and start off slowly. So it was a learning curve. I was not part of the clinical trials. So for my community side of things, it was a quick learning curve. And we've seen this over and over with TKIs, be it regorafenib or in my community practice, lenvatinib or anything. Exactly. So just starting off slow ends up being a whole lot better. And that's going to be my practice moving forward.
Aparna, thank you so much again for joining us. We've covered quite a bit here, and we truly appreciate you going over this treatment algorithm with us. For our listeners, let us go over a quick recap.
ctDNA has been a hot topic in almost every solid malignancy, but the colon cancer trials have been leading the path here. In this discussion with Dr. Aparna Parikh from Mass General, we touched upon how to use ctDNA in our current practice when it comes to colon cancer.
With Dr. Parikh, we also had a chance to understand how to sequence our current available treatment options in colon cancer, from immunotherapy to fruquintinib. We had a chance to touch on a lot of the recent data and looking for advancements in future. We appreciate you tuning in. Make sure to check out our hepatocellular carcinoma and upper GI discussions as well. We are the Oncology Brothers.